So I'm going to tackle just a couple of basic questions about Chiari that we've been looking at recently. I have no financial disclosures of any kind. I'm going to focus on just a couple of trends that I think are really important with understanding Chiari right now. Anybody that takes a long, hard look at this disease right now agrees that the 5 millimeter rule just leaves so much to be desired. It overcalls in some cases, it undercalls in other cases. It's not working. Everybody agrees about that. The trouble is nothing has replaced it yet. So we'll talk about that a little bit. And then the other, I think, very significant trend in Chiari right now is to connect Chiari with more and more and more things, and sometimes I think that that can get a little bit ahead of the evidence. So we'll talk about what connections have been established, what putative connections maybe haven't been well established but might be in the future, and so on. So again, we'll start briefly with this 5 millimeter rule, and we almost get into philosophy, I think, with this sort of thing. How do we define disease? This came up yesterday, and I think I'm led to believe it was somewhat controversial. Is syringomyelia a disease, somebody asked? Is it a disorder? That can't be answered scientifically. That's just something that you believe. Is a disease an MRI finding, no matter how you feel? Or to have a disease, do you have to have an MRI finding and feel bad in a certain way? Or do you just have to feel bad without a certain MRI finding? How are you going to define that? And nobody can tell you this is the right answer to that, right? That's just got to be something you come up with. You can't go to Webster's dictionary and find a definition that's going to work for everybody. We traditionally have been comfortable defining Chiari as a disease, and that disease is defined by 5 millimeters of tonsil position below the foramen magnum. Well, Chiari is a disease. We all agree Chiari is a disease. The question is, when does it become a disease? Does it become a disease really at that 5 millimeter mark, no matter how you feel? Or is it a disease at 3 millimeters if you feel really bad and you've got the classic symptoms? Well, yeah, probably, but there's a lot of gray area there. There's a lot of very interesting questions. And I think it's safe to say that you could hear scientific evidence presented for the next week or two, and you're not going to get an answer that clarifies that in your mind, because it just can't be done, I think, based on the existing data. So some of these you've seen yesterday, they come from our group. These are all people that measure more than 5 millimeters below the foramen magnum. The person on the left has pointed tonsils, looks very much like a Chiari malformation. It's always going to be called a Chiari malformation by any good radiologist. But back to the philosophical question. Let's say this person feels completely normal and healthy, is a perfectly happy, healthy person, and just volunteered for an MRI scan, and now we have this. Is that person diseased? Well, I don't know the answer to that. I don't know if anybody knows the answer to that, but they have Chiari by our definitions, by the imaging definition. Person in the middle is a little bit of a softer call, somewhat rounded tonsils, but also a little bit deformed. Person on the right, completely rounded tonsils. This is where it gets even tougher. Let's say this person has classic Chiari symptoms. Does that person have Chiari? Probably most people in the room would say, yeah, if the symptoms are classic, but I'm not sure I ought to operate on that because the tonsils look really good. Well, let's say the person feels completely well. It's a completely healthy individual that volunteered for an MRI scan, and now they've had an MRI scan. The radiologist has said the tonsils measure 5 millimeters below the foramen magnum. This is consistent with a Chiari 1 malformation. Neurosurgical consultation is recommended. Well, this is, neurosurgeons see this all the time. Does that person have a disease? I don't know. I would suggest that none of us have the answer to that. So problems with the 5 millimeter rule. Chiari 0. The group in Alabama defined Chiari 0, what was it, Leon, about 20 years ago or so. And they came up with this definition really for people that didn't measure at least 5 millimeters below the foramen magnum. They didn't meet that criterion. And according to the senior author on that paper, what he was really trying to get at is people who had a really tight-looking foramen magnum and had a SYRINX and the classic symptoms. They were defined as Chiari 0. In his estimation, this should be incredibly rare. I think there's a potential for overcalling Chiari 0, and that's dangerous because now we've lost our objective measurement. The one objective measurement we all kind of agreed on originally was 5 millimeters. Now that's out the window if we say Chiari 0 exists. So what's the objective criterion then? Well, according to the senior person who wrote the paper, well, it's objective because everything looks tight and there's a big SYRINX. Okay, fair enough, still pretty objective. Trouble is, it's a slippery slope, and now you're seeing that diagnosis made a lot for people that don't have a big cervical syrinx, that don't have classic symptoms, and so on. So no matter what we think about Chiari 0, it definitely represents a failure of the 5 millimeter rule for some patients, for sure. Asymptomatic Chiari 1, we talked about. So again, a patient with 7 millimeters below the foramen magnum but feels completely healthy. We call them Chiari 1, that's what the radiologists call them, that's what people think. But clearly a failure of the 5 millimeter rule. So I think it's at best a marker. Why do we use it? Well, because it's easy to do. Everybody can make this measurement. Every radiologist can make this measurement. Every neurosurgeon can make this measurement. And the other things that are probably a lot more important, like the relationship of the brain to the skull and posterior fossa volumes and deformation and so on, are much harder to measure. And nobody's come up with a real simple, reproducible way for everybody around the world to do that. So none of us really like it, at least none of us that are thoughtful about it like it, but we all continue to use it because it's easy, it gives us a common language when we're talking to each other, and also I think for historical reasons. This is really, I think, the paper that is probably most responsible for us adopting the 5 millimeter rule, the so-called 5 millimeter rule. And it comes from a radiology journal in 1986, Barkovich and others. Very commonly cited paper. And I think 1986 is important because MRI scanning came around the late 70s and then hospitals started to buy more and more of them. And by the mid-80s, all of a sudden, a diagnosis that we thought we were comfortable with in the 70s, we're not comfortable with anymore because we're seeing a lot more of it with MRI scanning. And so Barkovich and others attempted in the relatively early days of MRI scanning to come up with a more precise definition than a Chiari just is a Chiari. When I say it, it's a Chiari. They needed a number. And they came up with 5 millimeters. Here's how they did it. They looked at 225 patients. They looked at 25 Chiari patients and 200 normal patients. And I would suggest to you that 25 patients is a very small number of patients to base something that here we are 30 years later, we're still basing a huge part of our practices on this definition, again, a definition that they got from 25 patients. So a really small number of patients that they looked at, compared them to 200 people that were pre-selected for being normal. And then they asked themselves the question, well, what if we set a cut point at the foramen magnum? So what if we say everybody with cerebellar tonsils protruding at all through the foramen magnum? Would that be enough to define the disease? What would the sensitivity and specificity of that is? In other words, if we set the cut point right at the foramen magnum, would we capture everybody that has Chiari symptoms? And the answer was yes. And they said, well, would we also capture people who don't have any Chiari symptoms? Would we mislabel them as having something when they don't? And the answer was yeah, they would do that sometimes, they thought, in about 15% of cases. So they kept going down 1 millimeter below, 2 millimeters below, 3 millimeters below. And by the time they got to 5, based, again, I can't emphasize it enough, on their tiny data set, they came to the conclusion that 5 millimeters was 100% specific for a symptomatic Chiari. That is to say, if you had 5, you had a Chiari, by their definition. And the definition was born. There were some other important papers that came out around that time as well that contributed to this, but that was the main paper. But really very little was understood about tonsil position versus the foramen magnum for a long time. What is normal tonsil position? I mean, that seems like a simple question that we should all know the answer to, right? And actually nobody looked for a long time. There have been a few papers that have come out recently. The one on the right is from the orthopedic spine literature. So orthopedic surgeons that are doing a lot of scoliosis surgery. And in the past few years, they've been ordering MRI scans, some orthopedic surgeons, not many of them, but some orthopedic surgeons have been ordering MRI scans on every single patient that they see that has scoliosis, looking for intracranial abnormalities. And the curve you see on the right, this was published this way, but you could imagine if it's flipped 90 degrees on its axis, you see a little bit of a bell curve type shape there. And they've got that hashed line there at the foramen magnum. And these authors showed that in the scoliosis population, there quite a few people had low tonsil position below the foramen magnum. Even though it looks a little bit like a bell curve, and that's kind of the low end of the curve, But they thought, well, I wonder if that's important. Maybe scoliosis patients are more likely to have low tonsil position. But of course, there was no control group. That is to say, they didn't compare it to what's expected in the normal population, because what was expected in the normal population was not known. The graph you see on the left is from our paper, Journal of Neurosurgery, a couple of years ago. Brandon Smith was the first author. And again, you see sort of a bell curve distribution of tonsil position. And what I mean by that is here in the middle, this is 0. So this is the foramen magnum. So this tall bar here is people with tonsils. These are 30 to 40-year-olds, people with tonsils that are ending right around the foramen magnum or so. So that's a pretty common occurrence in this age group. And then you see from the most highly occurring tonsil position, you see a gradual drop off to people who have significantly higher tonsils and a gradual drop off to people who have lower tonsils as well. So sort of what we would call a normal distribution or a near normal distribution there. And it changes by decade. When we looked at it by decade, this was in a survey of 2,500 randomly selected patients from a larger data set of about 70,000 patients that were undergoing MRI scan for any reason. And we looked at it with Chiari's included, and then also with people with Chiari that had been diagnosed excluded. And again, depending on what age you're looking at, this is the first decade of life where you see there's this really wide distribution in the first decade of life. There's a lot that changes in the 0, 1, 2, 3, 4-year-olds. After that, things get pretty stable, and you can see normal or near normal distributions. We didn't quite hit normal curves in areas where there was just not enough patients, I think, to do that. But again, normal or near normal distributions showing the tonsil position is pretty much like a lot of morphometric measurements in the body. If I showed you height measurements or weight measurements or BMI measurements or head circumference measurements of the population, the numbers would be different, but the curves would look kind of the same. Okay, this is just how humans are built. We're morphometric. Most people are kind of bunched in the middle, and then the farther you get from average, the smaller the group you're in. That's how we're built. So where does Chiari enter into this? Well, Chiari are the low outliers, the people who are being defined as Chiari by Barkovich's rule, the 5 millimeter rule, are the outliers on the low side. And lots of those patients are symptomatic and lots of those patients are not symptomatic, but they're low outliers. This is a little bit problematic if you're looking for a Chiari gene. You would expect if there's a Chiari gene that you're going to not see a normal curve, a single normal curve with things just kind of flowing nicely into a 5 millimeter or lower. You'd expect to see two groups, a normal curve and then a group of outliers that have Chiari, a different sort of bell curve. Those are two populations, two genes, and the most classic genetic disorders where there's going to be one gene that accounts for it. In multifactorial diseases, in diseases that are caused by lots of genes, lots of different genes for different people or several different genes in the same person, you're not going to see that two population bell curve. You're going to see what we see here, a normal population distribution. So what this at least implies to me is that we're unlikely to find one gene that accounts for the vast majority of people with Chiari. Could we find 20 genes that could account for 5% each of people who have Chiari? Maybe, but we're unlikely to find one gene, I think, just based on this. Does age matter? I showed you a little bit how I think it does matter. This was the first article, 1992, Makulis and others, widely cited article. They looked at a couple of hundred patients and divided them into decade age cohorts, 0 to 10, 10 to 20, and so on. And looked at the tonsil position, and they drew this line. This was what they thought was the mean statistical line through their data. If you look at their individual measurements, it's sort of almost what we call a scatter plot, just kind of dots everywhere. But they did find that there was, based on a relatively small data set, a statistical trend of increasing tonsil position as we age. And I agree with that. That's sort of what we found too. But when you look at a much larger population of people, the trend line holds. If I only had one trend line it would go in the same direction at about the same rate. But again, with a lot more patients, you can see it's not as simple as that. It actually, on average, seems to drop in the first couple of decades and then go up. And it's pure speculation on my part, but people ask, you know, if this is really congenital, how come you get symptomatic more frequently in your teens, in your 20s, and your 30s? Why is that? That doesn't make any sense. Well, I think it makes sense when you're looking at these data. You can get symptomatic at any age. We all know that. But when are the tonsils lowest on average in the population? Well, right at the same ages that Chiari is most likely to become symptomatic and present to our attention. I'm making a speculative connection there, but to me it's interesting. So age does matter, and it matters when we ask how common is Chiari, because you have to follow that up. Well, I can't answer that question until you tell me what age we're talking about. Okay. So how common is Chiari in a 5-year-old age group is different than how common is Chiari in an 85-year-old age group. And I think that's very relevant when we're talking about prevalence studies. The most commonly cited prevalence study in the literature is this Meadows paper from about 15 years ago. And they looked at the Johns Hopkins radiology database. They looked at 25,000 people that had a scan for any reason, and a widely cited number, they found just under 1% or so of people had a Chiari malformation. So this is a number that gets thrown out a lot, and I think I have no reason to suspect that's not a completely accurate number. They looked at all ages being studied in that hospital. They didn't talk about what their age distribution was, even of the people getting MRI scans, and definitely didn't talk about age distribution with the finding of Chiari, but little less than 1%. We looked at kids and adults separately, and again, we're finding a higher prevalence in kids than all adults. Keep in mind that adults getting MRI scans, it's a skewed older population. You're more likely to get an MRI scan if you're older. So if you look at everyone getting an MRI, the mean age of that group is older, and you're going to be, go back a little bit, you're going to be looking at a mean age of somebody out here. And then you talk about Chiari prevalence. Well, that's going to be different than if you're studying a mean age that's here. Does everyone get that? Okay. So again, what is the prevalence of Chiari? Well, what age are you talking about? It's higher in kids. It's lower in adults. If you look at the whole U.S. population, I think it's probably just under 1% of an MRI finding, not of somebody who is experiencing symptoms of the disease. But it's definitely higher in kids, again, as an MRI finding, if we're using that 5-millimeter rule. What's the prevalence of symptomatic Chiari? Well, we don't know exactly, but it's definitely lower. This is the best, I think, published study looking at the incidence of symptomatic Chiari, Aiken and others. This was from UC San Francisco. And they looked at a group of people that were insured by Kaiser Permanente in Northern California, so it's sort of a captive group that they could follow. And of that 750 or so thousand patients that they followed, they had just over 5,000 that underwent an MRI scan, so that's just under 1% of this pediatric group. I should say they were all children. And 32 symptomatic children with Chiari on imaging. So 32 patients that had Chiari symptoms and had Chiari on imaging. So that's setting the threshold pretty high for Chiari diagnosis. So they found the symptomatic Chiari prevalence was just under 1 in 10,000. So that's very different than the prevalence numbers I just gave you for an MRI finding, right? Very different. This is work we're doing right now. It's still in its relatively early stages. I debated whether I should show you something that we're still working on, but I thought I would because it segues nicely to that last study. Kyle, who's sitting in the audience, wave, Kyle, there you go. Kyle has put a lot of this together this summer. So we're using the Optum database now, which is a large database of about 30 million patients in the United States. They do have private health insurance, so there's a little bit of a bias in this group. So 30 million United States patients with private health insurance. But we're looking at this database and we're asking how many people with private insurance in Optum are being diagnosed with Chiari at any given time using ICD-9 codes, and then saying how many patients in the United States are being treated with Chiari at any given time. And the interesting thing about this database is we can look at longitudinal trends. The same insurance company, again, normalized for the number of people with the policy. So in other words, if you had 15 million one year and 30 million the next year, it's normalized for that. But we can look at Chiari diagnosis in this country, and the trend is interesting. This is, you know, when the UCSF study was published, and I would postulate that our numbers are going to be higher, and that's okay. It's showing what's really happening in the United States. The diagnosis is just going up and up and up right now with no end in sight. And again, this is a clinical diagnosis. This is not finding on an MRI scan. This is somebody who sees a doctor and is assigned a clinical diagnosis of Chiari, and that's entered into their medical record and associated with a bill. Surgeries are going up as well. I was speaking with Kyle this morning, who again is putting some of these numbers together for me, and I'm told that actually this trend might be a little steeper because we need to normalize a little bit better. Kyle's nodding, so that's true. But here we see adults, and here we see kids, and these are people with the Chiari diagnosis who are also having Chiari surgery, and again looking at trends over the last 15 years, and the trend is up. There's definitely a lot more Chiari surgery happening in this country now compared to 15 years ago. And it seems to be more true for adults than for kids, which I think is interesting, although I think the trend is increasing for kids as well. So again, that's in a population of about 30 million people. This doesn't reflect my bias or some other medical center's bias. This is what seems to be happening in America, at least for people with insurance. So I've shown you a little bit about Chiari prevalence on imaging, which I think is a vastly different thing than people with symptomatic Chiari having surgery. Okay, so what do we use to define this disease? Do we use clinical criteria? Some people think yes and believe in that very strongly. Do we use imaging criteria? Again, we have our proponents for that too. And it kind of matters because increasingly patients are getting MRI scans and the radiology report says Chiari, and they go in to see the doctor, and all of a sudden this is a big problem. This is a really big problem for them to work through, navigate the medical system, and try and understand what's going on with their bodies. And it's becoming an increasing issue, this difference between MRI findings and clinical issues. And the reason for that is our increasing use of MRI. This is a JAMA article showing essentially the trend of MRI use in this country. Not surprising, I'm sure, to anybody in this audience. It's just going up and up and up and up. These different lines here represent different regions of the country. And without going into too much detail, I'll just say that basically what it shows is that it matters where you live. If you live in one region of the country, you are significantly more likely to be given an MRI scan than if you live in some other region of the country. So big regional differences. But no matter where you live, if you live in the United States, you're much more likely to have an MRI scan now than 10 years ago. And the United States is an outlier. Even in the first world. This is a slide I got from the Office of Economic Cooperation and Development, which is a non-governmental agency based out of Geneva, Switzerland. And go to their website. They have a lot of really fantastic statistics that they track health trends around the world. And if you want to know how the US stacks up to Canada or Britain or Japan or Mexico, it's all there. So this is their most recent graph looking at MRI usage in America versus the rest of the world. This is the OECD 11, so again, first world countries. Average MRI scan usage is 41 for every 1,000 per year. In the United States, it's 90 per every 1,000 per year. This is 5 years ago. Again, the most recent graph they had, so I used it. The actual data shows that we're actually over 100 per 1,000 per year now in the United States, so it's gone up. And I would suggest to you that that's a lot of MRI scans. But who's getting them? It's not evenly distributed through the population. For the most part, it's a distribution that's skewed towards the elderly. That's who's, for the most part, is getting MRIs. So again, I'll leave this part of my talk, again, with the question. I think I started with how do we define disease, and I would suggest that really there's not a consensus about that, and I don't think we're going to reach a consensus today. There's a lot of things that you have to take into account when you're trying to answer that question. Again, we all agree that this patient on the left with the SYRINX, with a significant Chiari malformation, probably symptomatic, we all agree that person has a disease. But what about this person? No symptoms, no SYRINX, 5 millimeters, tonsils below the foramen. Does this person have a disease? I don't know. I don't know. The National Institute of Health has not really reached any conclusion about this. I usually give Dr. Heiss a little bit of a hard time when I see him about this, but this is the NIH's website. And when you want to learn about Chiari malformation and you go to the National Institute of Health website, which is a great resource for people with all sorts of health problems, you find Chiari on their website of the Office of Rare Disease Research, and that's where the funding comes from, and that's the NIH's mechanism of dealing with Chiari issues, is the Office of Rare Disease Research, Chiari malformation. So NIH, I guess, considers it a rare disease, right? Well, not so fast, because this is, I didn't put this little asterisk there. It was there. It's there on the website. And when we blow it up, it says, asterisk, not a rare disease. So it's a little bit of a mixed message there, I think, even from our own National Institute of Health, that Office of Rare Disease Research, Chiari malformation, it's not a rare disease. So we'll see where that moves in the future. I want to tell you briefly about natural history of Chiari malformation, because again, it's being diagnosed a lot. I think everybody in this room, if not at least the vast majority of people in this room, if you have a Chiari malformation, it's probably a symptomatic Chiari malformation. Otherwise, you probably wouldn't have made the effort to come to this meeting and talk to physicians at this meeting. But as neurosurgeons, sometimes we see the other end of that telescope. We see a lot of people that are feeling great and have an MRI report and it says they have a Chiari malformation. So what happens to those patients? Are they going to be okay 5 years from now? Can we tell them, good luck, you're going to be okay? Is that a truthful statement? We really had no idea about that until a few natural history studies over the past couple of years. The first one was Novegno and others. It came out of Rome, Italy. They looked at 22 patients, followed them for 6 years. Not all of them were strictly asymptomatic, and they said that 6 patients had new symptoms and 3 of them had a Chiari decompression. So 3 out of 22 in 6 years. Pretty small study. They concluded that most people did okay, that presented doing okay in the first place. Here's a Miami group. They had 124 patients, sort of the same thing, 124 patients that were doing okay. They chose to not have surgery up front because they preferred not to have surgery. They found that 14 out of 124 patients over about a 9-year follow-up did develop new problems. 5 of them got worse to the point where they needed surgery. So that's 5 out of 124. It's a pretty good long follow-up, developed problems that they actually wanted to have something done about. So that's a pretty small number. I guess it depends if you're glass half full or glass half empty. But the glass half full take on that would be actually you got a pretty good percentage chance if you're asymptomatic or minimally symptomatic of moving forward without needing anything done in the future. This is our natural history study, which came out at the same time as the Miami group. And we looked at 148 patients. We had a 5-year follow-up, and we had 16 patients that ultimately had a Chiari decompression. Word of caution about interpreting that doesn't mean 16 patients out of 148 got worse. In our series, that meant that 16 patients that we initially decided to not do surgery for and kind of see how things went, 16 out of that 148 went on to have surgery. In some cases, in fact, in most of those 16 patients, it was a matter of symptoms that were persistent. They didn't seem too bad at first. Somebody thought they'd live with it, and 6 months later they said, you know, this doesn't seem like a great idea. This isn't going well. So 16 out of 148. Again, glass half full take on that is a very small minority of people who choose to not have surgery up front do okay with that over a relatively longer follow-up. What happens to the MRI finding of a Chiari over time? Again, these are our data from a natural history study. And again, we see one of these bell curve distributions. The big line in the middle indicates that most people don't change over about a 5-year follow-up. You keep getting MRIs and it keeps looking about the same. But there's not an incredibly small number of outliers. Some of whom are changing a lot. This is somebody who got, a group of people that got 8 millimeters better, 6 millimeters better. That's a lot in a few years. And we also had people who got worse, too. So when patients or families ask me, well, I feel okay now, I'm not going to have surgery, what's going to happen in the future? Am I going to be okay 5 years from now? The truthful answer is, well, I don't know how any individual person will be 5 years from now. But on average, most typically, they're not going to be worse symptomatically, and most typically they're going to be about the same on the MRI over about a 5-year interval. But there's outliers that get significantly better and significantly worse. Followed over many decades, nobody's done that study. What happens if we follow somebody for 30 years, 40 years? That's the study that has to be done, and maybe it will get done someday, but it hasn't been done yet. And the best I can speculate, again, is based on our MRI prevalence data that shows the tonsils just keep going up, 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 up throughout life. I would speculate that if we can wait 30 or 40 years, a lot of people's MRIs are going to look better. That's what the average is going to be. Okay, but nobody's done that study strictly with a natural history analysis up to this point. So I'll conclude the epidemiology part of this talk. How much time did I give myself? We'll go a few more minutes if that's okay. I'll conclude the epidemiology part of this talk by just, again, pointing out some things that I believe, just my opinions. I think that the 5 millimeter rule that we all use, that we all talk about, is a seriously flawed criterion. I consider it not a cut point that has definite pathological implications. That is, I don't say if you have 4.5 millimeters, you don't have a Chiari. And if you have 5.5, you do. It's just not that simple. It's not that simple at all. So I don't consider it a cut point with definite pathological implications. I consider it the low end of a normal distribution curve. And normal doesn't mean normal, it means bell-shaped. So we have this distribution curve, it's bell-shaped. And the people on one end of the distribution curve are more likely to have Chiari-type symptoms. And we call that group of people, people that have Chiari malformation. Okay. Symptomatic Chiari does seem to be relatively rare. Again, it's not that rare, but it's definitely rarer to have symptomatic Chiari than all of the asymptomatic Chiari that we're now finding on imaging. The natural history for asymptomatic or minimally symptomatic individuals is good in most cases, not in every case, and we can never predict the future of any individual with certainty, just populations. I'll segue just very briefly into looking at some of the associations with Chiari. We've talked yesterday, and we'll talk again today, about some of these other diseases that have been associated with Chiari, and I want to look at the evidence for some of that. I'll start with the easy one. Is Chiari associated with SYRINX, right? That's pretty easy. Here's a patient, significant Chiari, tonsils way down into the spinal canal, very significant looking spinal SYRINX, okay, very large, very high. This is a no-brainer. You show this to 100 neurosurgeons, they're all going to say, yeah, this is somebody with a Chiari malformation and syringomyelia, and I would bet my life that that SYRINX is being caused by that Chiari malformation. Here's another one. I think most people would say the same thing. It's probably a little bit less of a significant Chiari, though still absolutely a real Chiari. Significant spinal SYRINX. We'd all pretty much agree on that one too. This is somebody that has a Chiari that's causing their spinal SYRINX. It would be not a controversial decision in the least to recommend surgery for this patient to fix not only their Chiari, but by so doing to fix their SYRINX. Well, here's where it gets tricky. Here's where it gets controversial. What about somebody, you can't see their foramen magnum, but let's say they have a Chiari, okay? Let's say they have a significant Chiari on MRI scan. And now they have this finding in their mid-thoracic spine. It's a SYRINX. Let's say it measures 7 millimeters in its maximal diameter. So by any of the normal definitions of SYRINX in any kind of research paper that we can write on a SYRINX, it would count as a SYRINX. But it's lower, isn't it? It's mid-thoracic. It's not up here next to the Chiari malformation. The cord that is next to the Chiari malformation, the cervical cord, appears very normal. Okay? And it's not as wide as these guys, right? So here's where we get into some controversy. let's say this person again had a significant looking Chiari malformation on MRI, but was otherwise asymptomatic. Can I use that finding as a justification for doing a decompression? Well, I'll show you some data and tell you what I think about that, but that's going to be the question that we have to ponder. Here's another patient. Same location, mid-thoracic, even smaller syrinx. I mean, this is a tiny guy. This is, if you want to call it 3 millimeters, really tiny. These are the kind of guys that end up in some of the SYRINX research studies if you set a minimum entry criteria of 2 millimeters or 3 millimeters, which is the standard in research. But this is something that, I think a lot of neurosurgeons would not get terribly excited about fixing with an operation, because it wouldn't be clear to any of us that we could offer anything that could help. So again, the middle one is probably the most controversial, this one here. Probably a little bit more certainty about these two. So let's look at some data. This is all taken from a paper that we wrote in Journal of Neurosurgery recently. I'm not going to show you too many graphs, just a couple. But basically what this shows, this is the width of the syrinx on this y-axis. And these are different types of what we were calling associated pathology. So all of these patients had a syrinx. And some had a Chiari, and some had an untethered cord, and some had a tumor, and some had dysraphism. Some, we couldn't find anything. We didn't see any evidence of tethered cord. We didn't see any evidence of Chiari. We didn't see any evidence of tumor. And we call those the idiopathic syrinx, or primary syringomyelia. Okay. As pointed out yesterday, idiopathic meaning we don't know. So when we look at syrinx width by these categories, Chiaris in general, higher is wider, by the way. So there's a big range. But on average, Chiaris have pretty wide syringes. It's 8 millimeters here, so pretty wide. Same thing with, we had a small group of what we called Chiari 0. So again, a tight frame and magnum with a syrinx, but not meeting the 5 millimeter rule. And at least by our entry criteria, Chiari 1 and Chiari 0, we're basically looking at the same kind of syringes in terms of being very wide on average. And same thing with a small group that we called a secondary Chiari malformation. So people that had a Chiari that was being caused by something else in the brain, kind of pushing the tonsils down, cysts and that sort of thing. They essentially, at least for the purposes of what the syrinx looks like, they essentially look the same. They had wide syringes. By the way, nobody can agree if it's syringes or syrinxes, so you might hear me say both. So again, really wide up here. Contrast that with the ones in the blue circle. Well, what are these? Well, this is the idiopathic group right here on the left. This is a group that we don't know why they have a syrinx. We couldn't find a Chiari, we couldn't find a tethered cord, couldn't find anything. They tended to have these skinnier syrinxes. And same thing with the tethered cord syrinxes, tended to have the skinnier syrinxes as well. We can look at it a different way, again, dividing up our group by the associated conditions, Chiari, tethered cord, and so on. But now we're looking at how far away is the syrinx from the top, from the foramen magnum. Okay, so the smaller the light gray line, the higher the top of the syrinx is. So in other words, this group up here, these are really high. This is Chiari up here, Chiari 1, Chiari 0, secondary Chiari. Okay, so you can see that for the most part, the patients that had a Chiari also tended to have really high syrinxes. There's always outliers, but that's what the general trend was. Compare that again to the idiopathic tethered cord group. They tend to be significantly lower in the canal. This second vertical line is 10 segments. So that's thoracic. That's upper part of mid-thoracic spine on average. For idiopathic, tethered cord was even lower. Low thoracic lumbar is what we're talking about there. Again, you can analyze this 100 different ways, but to keep it relatively straightforward, today, again, we've put both of those pieces of information now in the same graph. So we're saying if we know the width of the syrinx, how big it is, how wide it looks, is it skinny, is it wide, and we know how far away from the foramen magnum it is, what does that tell us about, does this person have a Chiari or not? You know, if that's all we know, if we know what their syrinx is, does that predict if they have a Chiari or not? And pretty much yes. There's an overlap, but pretty much yes. So Chiari is red, and idiopathic in this graph is blue. So for people that had a completely normal foramen magnum and didn't have a Chiari of any kind but did have a syrinx, well, you can see that in general the syrinx was lower. That's higher on this graph. It's kind of confusing, I admit. But lower syringes and also skinnier syringes. The closer they are to the left, the skinnier they are. People with a Chiari were much more likely to have wide, big syringes, and also syringes that were very close to the foramen magnum. So for the most part, we're talking about cervical spine syringes. So again, here's the Chiari group, and here's the idiopathic group. And in between, you can see that there's definitely some overlap. So what does this tell us? Well, again, this is a typical Chiari with a syrinx. It tells me that if I fix this, something all the surgeons kind of already knew, this is going to get better the vast majority of the time. So that seems like a good idea. Same thing with this one. But at least based on my data, not this one. So if this person has an extremely symptomatic Chiari, they have tussive headaches that are interfering with their quality of life, they have other Chiari type symptoms, well, maybe we do the Chiari surgery for those reasons. But I'm not going to tell this patient that their syrinx is likely to be improved from my Chiari surgery because this is just as likely to be a coincidental association as a cause and effect relationship. And if I can't prove a cause and effect relationship, I have great reason to doubt whether my intervention at a putative cause is going to have any effect on the effect. Same thing here. I personally would never tell a patient that I'm going to do anything to address this sort of a finding in the mid-thoracic spine with a Chiari malformation. So for me, based on the data that I just showed you, my opinion right now, my bias is that I think these are Chiari-related syrinxes. I think that these clearly are not, and I would not recommend Chiari surgery for either of those syrinx types. So is it associated with syrinx? Of course it is. We all know that Chiari can cause syrinx, but there's lots of exceptions. Not all Chiari patients have syrinx. We used to say about 70% did, but that was based on surgical series because surgeons were operating on the patients that had syrinx. So that obviously it's a bias. If you look at population studies, the number is much, much, much lower. Not all syrinx patients have a Chiari. Obviously, there's lots of causes for syrinx. In the pediatric population, Chiari is the most common cause that we see for a wide syrinx, but it's not always the cause. So just as the speakers told you about yesterday, you got to look for other causes. We're looking for tethered spinal cord, we're looking for tumors, and so on, and we don't automatically implicate the Chiari, especially if it's low and especially if it's skinny. Not all patients with a Chiari and a syrinx have a Chiari-caused syrinx, and again, that just gets at the data that I just showed you. How are we doing for time? I'm going to go just a couple more minutes. We'll talk about hydrocephalus and then we'll finish. Is Chiari associated with hydrocephalus? We've heard from other speakers that it is. I have to be honest, at first I was a little bit of a skeptic about this relationship. And the reason is that you see it over and over again where somebody has a good-looking MRI scan, they don't seem to have hydrocephalus, and then they get what should have been routine Chiari decompression, and then they get a spinal fluid leak. And you see it so often that, well, it's because I had hydrocephalus, and they put in a shunt right away after my spinal fluid leak. And I think that that's true, and that does happen, but I also think, in my opinion, it's overstated, and that in many of those cases, what that represents is a dural closure that wasn't quite what it should have been or could have been. And it's not necessarily hydrocephalus. It might have been, but it wasn't necessarily hydrocephalus. So again, here's two examples of patients with what we call pseudomeningocele. So they've had a Chiari decompression, and they've got all of this white area back here. This is spinal fluid, and it's not supposed to be there. It's leaking out their patch. It's causing all sorts of bad symptoms. Usually patients with pseudomeningocele are very symptomatic from it and are quite unhappy. I would say in the United States right now, it's not unusual for patients with this clinical scenario, even immediately after a routine Chiari decompression, to have a shunt placed and to say, oh, well, the reason this happened is because you have hydrocephalus. Well, maybe, but I think we got to prove that first. So I think it's overstated. Here's a patient. Dr. Iskandar showed a similar patient, I think, yesterday. Came to see me. I thought no hydrocephalus. Ventricles really didn't get my attention at all. It's very symptomatic Chiari. I did a Chiari decompression. Thought everything went great. And here's a post-operative MRI. Patient didn't have a high syrinx before, now has a syrinx. I thought didn't have hydrocephalus before, now has hydrocephalus. So what happened? Well, this is somebody that I caused hydrocephalus in, and that definitely happens. It should happen very, very rarely. I think even in a very busy Chiari practice, this is something that you should see once every few years at most. It should be a very, very rare phenomenon. I used to say it never happened, and then I was humbled by this situation because this happened to me. You got to take care of the hydrocephalus in that situation, and the patient did get better. What about this patient? This patient presented with symptomatic Chiari, a big spinal syrinx, and this patient I did think had big ventricles. So what are we going to do? Which came first? This is cyclical, isn't it? Did the hydrocephalus cause Chiari? The Chiari cause the hydrocephalus? And I've gone back and forth on this, frankly, in my practice. This is somebody a couple of years ago that I chose just to start with the Chiari. And here's the intraoperative findings: cerebellar tonsil on the left, cerebellar tonsil on the right. And you can see here we're dissecting through this relatively thick arachnoid band here that was almost completely or completely occluding the fourth ventricle, and just some kind of sequential slides of opening that up. This is somebody I was worried about might need a shunt, but based on those intraoperative findings, we decided to not do that. Again, here's just looking after we've opened it up, a little view into the fourth ventricle, and you can see the really dense arachnoid adhesions on each side of it. This is not a redo case. This is the first operation. Based on that, I decided not to shunt that patient, and that patient did well. I don't have slides for this, but I tried to do the same thing about a month ago, and again was humbled because this person I knew had hydrocephalus, had an empty cella appearance on MRI, had papilledema on a fundoscopic exam. I said, I've seen this before. I'm going to try to just do a Chiari decompression and see how it goes. And that patient did present with a CSF leak postoperatively, and I think ultimately needed treatment for the hydrocephalus up front. So I think that there's really not any firm guideline for how to approach those difficult patients, but I think that I can conclude that hydrocephalus is definitely associated with Chiari, but I think the association is really, really rare. I mean, I think if you're seeing 100 Chiari patients a year, I've seen it maybe 1% or less of the cases that I see. And I think if you're seeing a lot more than that and you're associating it with everybody that you ever get a CSF leak with, I think you're probably, in my opinion, probably too quick to diagnose the hydrocephalus when in fact you could just fix the dural closure. Pseudomeningocele is not usually, in my opinion, caused by hydrocephalus, and pseudomeningoceles should not be treated with a shunt as a first line of therapy. I think I've run out of time. Since this has appeared, I'm just going to say chronic fatigue. About a decade ago, this became very controversial in the Chiari community. And people were starting to do Chiari decompressions for people that didn't have traditional Chiari symptoms and had no SYRINX on their MRI scan. And the AANS, which is our main organization nationally, the American Association of Neurosurgeons, actually came out with a position statement about this in 2009, saying that they do not recognize cervical decompression, that is to say essentially Chiari decompression, as a treatment for chronic fatigue syndrome. This is something that had bothered a lot of neurosurgeons. The AANS doesn't make a lot of position statements. Here's a list of every single position statement that our organization has made in the last 17 years, sorry. So over 17 years, you can see we've had only a handful of position statements, and one of them is about Chiari and chronic fatigue. So it's a issue that a lot of people are emotional about, and I understand that. But in my opinion, we've never seen any good scientific evidence linking the two. I personally never do a Chiari decompression for chronic fatigue. And again, our organization actually has an official position statement against doing that. So I'll stop there to give us some time for questions. And if I could ask the other panelists that were part of the morning session to come down. Thank you.